California's Secretary of Health and Human Services announced that masks will once again be required of all Californians in public indoor settings, regardless of whether or not they are vaccinated. The mandate, which goes into effect Wednesday, will last through January 15th. New York is also requiring masks inside public places, except where a vaccine requirement is being implemented. The mandate, which went into effect yesterday, will be reassessed on January 15th. Similar mandates have also been popping up in cities across the nation. Given what we know from clinical data, are government officials following the science? Joining me now to talk about this and more is Dr. Andrew Bostom, a clinical trialist and associate professor of family medicine at Brown University. Dr. Bostom, welcome back to Washington Watch.
Thanks for having me on.
Well, there's a lot I want to talk to you about, but I'm going to start off by talking about the Omicron variant. On Friday, White House COVID-19 response team held a press conference during which CDC Director Rochelle Walensky reported on the first 43 cases of Omicron in the U.S. Here's what she shared.
Nearly 80%, or 34 individuals, were fully vaccinated. And about a third of them, or 14 of those 34 individuals, received an additional booster dose, though some who had a booster had just recently received it. Additionally, 16% of the cases reported had been previously infected with SARS-CoV-2. Among all cases, there was only one hospitalization, and no deaths have been reported to date.
Dr. Bostom, when you hear that, does that justify new mandates like we're seeing in California?
Well, no. Masking is futile to begin with, so nothing really justifies masking. There's ample randomized controlled trial evidence, the gold standard evidence that we apply to any therapeutic or intervention, from something as complex as a vaccine to something as simple as a mask. And there's been about 360,000 persons enrolled in community clinical trials of masking since 2008. It's 14 studies at least altogether now. 13 of them have been reported in peer-reviewed journals. There's one study that hasn't been reported in a peer-reviewed journal yet, but it's been published as a preprint, and it's the biggest study. And there's a uniformity of outcome. That, i.e., that whether it's influenza in the older trials, pre-COVID era, going back to 2008 through 2019, or the trials that address COVID directly in community settings in Denmark and in Bangladesh, all the data are negative. I mean, so it's just, you rarely see something that is, well, actually, you never see something where it's so consistently negative, and yet, really, clinical trials exist to make recommendations. In other words, if the trials are positive, or the bulk of the trials are positive, you make a recommendation that cholesterol lowering with statin drugs is useful, antihypertensives are useful for preventing stroke and heart failure and things like that. You make recommendations for their use. I've never heard of something being mandated as opposed to recommended when the randomized trial evidence is uniformly negative. So it's an absurdity to begin with. But the reassuring things so far about Omicron, about the Omicron variant, and this is mirroring what was reported in South Africa, in their epicenter in a province, I believe it's called Gauteng. It's Gauteng. What they're finding is that it is at least in their population, much milder in terms of hard clinical outcomes. They're not seeing hospitalizations. In fact, those that are in the hospital that have tested positive, about 70% of them were incidental. In other words, they tested positive, but they were actually admitted for something else. They're on room air. They're not requiring supplemental oxygen. There was one death reported in the UK from the Omicron variant, but Prime Minister Johnson was pretty clear in his language that the individual died with the Omicron variant, which doesn't indicate necessarily that they had a pneumonia and complications and died from COVID, from the Omicron variant. Dr. Walensky was very vague about the one person out of the 43 that was hospitalized, didn't even give the age, whether it was an incidental finding. But what is consistent is that these infections, and again, mercifully, they seem to be mild, are certainly occurring in those that are both, doubly vaccinated and even triply vaccinated. And she mentioned that some had occurred in people with prior infection. By and large, prior infection or naturally acquired immunity has been more robust, certainly in terms of clinical outcomes till now. What we know from a huge database that was just reported on last week of 18,000 roughly purely breakthrough infections was that when they looked, so these are all people that were fully vaccinated, or at least by the prior definition, they had 2 shots. What was found in this large insurance claims database was that having a history of prior infection, again, all these people were breakthrough post-vaccination infections, but having had a history of a prior infection before being vaccinated, reduce the risk, in this case, of serious morbidity. So hospitalizations and deaths, reduce the risk of hospitalizations by 50%, by twofold, and reduce the risk of death from COVID by 4-fold. So, a lot of evidence accumulating now about the strength of natural immunity. And all these reports, I'm glad the CDC director mentioned, there were a few cases that had a history of prior infection, and all of them seemed to be mild. But really, it's simplistic to break up, the vaccinated versus the unvaccinated. It's also this. As far as I'm concerned, it's ethically challenged. But beyond that, clinically, it makes little sense now when we see how important overriding impact is of naturally acquired immunity.
Sure. Let me jump in on that. There's a lot to talk about here, but why are the decisions being made in your judgment that are being made, like in California, if you think the evidence is quite clear that masks are futile, as you say, and also the continued emphasis on vaccines when, as you suggest, the evidence seems to be growing that natural immunity is quite effective, and no place that I'm aware of would allow proof of antibodies as a substitute for an actual vaccine where vaccines are required?
It's been very disturbing to me to see principles of epidemiology as I learned them originally, and most of my work, after being trained was in cardiovascular disease and chronic kidney disease epidemiology. But the last 2 years, I've been forced to reacquaint myself with basic infectious disease epidemiology, and all the things that we're doing go against what was common practice right up until COVID. And you could give the decision makers a little bit of leeway because, of the novelty initially, but within the first certainly 6 months of COVID presenting, everything that was true previously in terms of influenza pandemics, for example, was true of COVID, that these measures don't work, that they're very destructive, particularly the lockdown scenarios that were applied to people. And it's futile. You can leave people the option of wearing masks. I mean, that's been quite commonplace in Asian countries, as almost as a custom. But really, we have to go back to the metrics that we typically use to evaluate interventions like masking. And they were negative for influenza before COVID. We've got at least 2 large randomized trials. One is just humongous. The trial in Bangladesh was 342,000 persons, and the interventions just don't work. So to me, it's a form of old sort of Soviet style science, Lysenko and his ridiculous genetic experiments that led to crop failures, to just keep imposing this. It seems like more a form of control, honestly, in the end.
Well, and let's talk about, you say that the interventions just don't work, and certainly masks are one of those. Now, everyone's familiar in medical environments, masks are used commonly, and there's a belief that they are effective. Why then, if they are using them and they are using them effectively, why do you say they just don't work?
The commonplace surgical mask is used to keep the surgical field clean, but actually, which is very different than trying to combat a respiratory virus. I mean, if you're dealing with something for example, in biowarfare labs or virology labs with really dangerous pathogens, then they wear basically a hazmat suit. So I mean, if that's what you want people to wear, then that's what they'll have to wear. But really, the tradition of surgical masks was really to try and keep the surgical field clear of sputum and even there, I have to say honestly, when you review the surgical literature, what was actually found was that enforcing unmasked silence, so surgical fields that were surgical suites that were silent, where silence was enforced, so no talking, no moving of the air, signals, knowing what was. That actually reduced, surgical infections. Masking per se, did not. So even in medicine, it's basically been a tradition. The one study that I did see that was a randomized controlled trial comparing the N95 masks amongst healthcare workers to the surgical masks really showed no difference. And I think it shows you how daunting it is to deal with the physics really of these tiny particles and physical barriers. Again, short of things like hazmat suits.
As you talk about that, there is a small part of me that's concerned that we might see soon mandates to be silent and wear hazmat suits, because it would in fact probably save one life.
We're social beings. We're social beings. We communicate with
not if we're dead. We're not.
And talking, it's an absurdity, and that's why it was felt to be, again, prior to this outbreak, it was felt to be cruel to impose these kinds of things on people, particularly children, and there it's really egregious because children are at such low risk from COVID. Thank goodness, to impose masks on them is just really inappropriate. Many
of us maintain that it still is cruel to do that to children. I want to change the subject a little bit on you because there's a lot of us who feel like the goalposts are constantly moving. There's this vague concept of herd immunity out there that those of us who are not doctors heard about, that basically we think that at some point when everybody's been exposed to something, then it stops spreading. But it seems that with vaccination rates and those who have some kind of natural immunity, that we have at least reached that level where we were told we would have achieved herd immunity. Tell us what's happening.
Yeah, it really does depend on the definition of herd immunity. So if you go back to the 1920s when the concept really evolved, before mass vaccination campaigns, with the possible exception of some ability to vaccinate against smallpox, it simply meant when enough persons had recovered from infection in a population that there wasn't not only just wild spread, but symptomatic spread of serious illness that caused people in that era, to die in the streets or to wind up in the hospitals as they existed back then. In other words, breaking that kind of a wave, breaking that kind of phenomenon, it was a very different kind of definitions. Now, it looks like there may be pockets of the world and populations because of lots of natural infection that have achieved that. It looks, or at least temporarily. That's the other thing. A new variant can upset that balance. But if you look at Sweden, for example, if you look at India, they may be in that state of equilibrium, right now. They're certainly not seeing the kinds of waves of infections that are, raising hospitalizations and deaths now.
You mentioned variants there, and that's something else that we're all kind of confused about. We've seen Delta, we now see Omicron. Does this ever end?
Yeah, well, the only historical precedent vis-a-vis coronavirus I've read about now is something that was called the Russian flu, which actually turned out to probably be a coronavirus from 1889 to 1891. And what happened with that, again, it's now believed to have jumped from cows. It was a bovine coronavirus, and it infected humans, caused a pandemic, and it looks like it morphed into something that now circulates as one of the, prior to SARS, 4 common cold-causing coronaviruses, one called human coronavirus OC43. That is, again, basically a cold-causing coronavirus. Kids get those kinds of viruses once or twice a year. They're a common cause of colds in all age groups. They rarely still to this day can cause a serious outbreak in a frail population, like a nursing home population. But basically they circulate as endemic, it circulates as an endemic cold causing virus. The hope would be perhaps something like an Omicron variant, or maybe something, milder than that would evolve and eventually, infect lots of people and give at least enough cross-reactive natural immunity to prevent, serious outbreaks. But, that's really speculative, but that is an historical, precedent.
Dr. Andrew Bostom, Brown University, we appreciate your time. We are sadly out of time. I got so many more questions I'd love to run through. I think we're going to have to do this again because curious minds really do want to know. And those of us who are not doctors are frequently confused about what we're seeing. But we appreciate you spending some time and illuminating us today. Thank you so much.
Thanks for having me. Take care.